pleasure to welcome you today to a webinar in the innovation track in the Imagining 2029 series of EHTEL. The EHTEL members have selected this topic as I would say an important and very actual topic. And it is true that with the recent COVID pandemic, the need to make use of data and to activate the data which were produced in the context of care has become a priority for many authorities. And thus, behind that, the question of making those data activable and how. This is why we are today speaking again about semantic interoperability, but I would say it's not like 10 or 12 years ago where we were just thinking about interoperability in the context of cross-border care with only one single use case in mind. Today, there is much more at stake. This is about creating really a health data ecosystem, creating the possibility to do it. So using data for knowledge management, clearly for epidemiology, but also for research and for many other things.
Good afternoon to everybody. Indeed, it has been a long journey. I think I joined the design of these infrastructures in 2011, and now we are full speed finally. So let's take a closer look at the Myhealth EU services and go a bit deeper on the semantic interoperability part. So what is currently Myhealth EU? We also call it EHealth digital service infrastructure, but it's easier for everybody to understand. Let's say more patient-friendly, citizen-friendly term, Myhealth EU. It's the infrastructure that connects currently 10 member states, which are in production. And it offers two services at the moment. It's patient summary and electronic prescription. And we're looking into expanding this infrastructure to cover further data types, further types of documents and health data. So what the services are for? What is the common goal of Myhealth EU? It's support for continuity of care when people exercise their right of freedom of movement within the European Union. Plus, it also covers, hopefully soon, EEA countries such as Norway, Iceland, hopefully at some point also Liechtenstein. So when people move, the data follows them, be it patient summary or e-prescription. And the idea is that the e-prescription could be dispensed in the future any country of the European Union, and also the patient summary would be accessible by any healthcare professional you would like to share the data with. And of course, for that, we need to provide appropriate tools for both health professionals and to patients. So patients need to see their data, maybe provide consent to data sharing. Health professionals need to have the tools to access the data. So to have this access either integrated in their system they currently normally use, or to provide it as a separate portal. While doing all this, we of course need to keep in mind data protection and security to not share any further than what the patient has agreed to. And of course, we need to make people aware of the services and to keep them stable and up to date. Because if people are not aware of the existence of the services, then it's not serving their best, their interests in the best possible way. So to give an example how this works, I took this picture from Finland, but it's very similar in other countries as well. So in the middle, you can see the Finnish infrastructure, which is SANTE in this case. So the patient, they would need to provide a consent for data sharing across the borders. So in this case, they would log on to a patient portal and provide that consent to the data sharing of electronic prescription. And then they go to a pharmacy abroad, they show their passport or ID card, the pharmacist enters the details on their computer, and then the prescription is fetched from Finland in this case, and when dispensation is performed, the data is sent back to the country of prescription. And this is functioning at the moment, so it works currently in Estonia, in Portugal, in Croatia. In these countries, you can purchase medication on the Finnish prescription. But we want, of course, to expand to further countries, and this is a a roadmap, as I could call it. It's not very precise, but you can see the big blob of countries joining rather soon. So some of them have joined already. You can see them as well. And then in wave 6, wave 7, 2022 to 2024, we'll have many countries joining or expanding their services, and then the rest of the countries follow in 24-25. So, so far, the traffic is still quite little because there are not many countries yet. So it's 10, and the coverage is not as perfect as it could be. But you could see already in the previous slide that we are moving very quickly forward with expanding the services. So since 2019, when the first services were launched, we have seen 26,000 e-prescription transactions, just half a thousand of patient summary transactions, and the number of hospitals, points of care, citizens able to benefit from Myhealth EU services, it's growing currently rather rapidly. So in some countries, there is 100% coverage of hospitals and pharmacies. In some countries, it's still on the smaller side, but we are increasing this steadily. So what is the scale in a broader context? I think we can take a look at the mobility of EU citizens of working age. And here on this slide, you can see that the blue bars are longer than the yellow bars. So that's an increase in 10 years. So there is more and more mobility of people moving from country to country, in addition to those simply going as tourists from a place to place. So this is only about those who are resident somewhere, mobile, working somewhere. So there is a lot of potential for these services, even if we only concentrate on basically those mobile people who don't go as tourists somewhere. With that in mind, we are expanding the services, and it has been taking quite some years to develop all the semantic interoperability and all the technology for doing this. And now we have something stable to build on and to expand it with further data content. So from this year, the system also supports the exchange of original clinical documents, meaning something which is PDF, for example. It's not possible to translate the document into the target language understandable in all cases by the health professional, but at least the data is available in its original form, and it could be taken into account. E-prescriptions and patient summaries are normally translated using code systems. So the same code has multiple designations in different languages, and that's why it's possible to translate the key data on every e-prescription and every patient summary. Plus, of course, there could be some narrative data in addition to that coded data. In original clinical documents, it's PDF only, but even that PDF is very useful in some cases. From 2024, we are working towards adding support for lab results and reports, medical images and reports, hospital discharge letters or hospital discharge reports. And that's where the EHealth project is now working on. They are developing interoperability specifications. It's a European project, and the results of that project will be fitting in this infrastructure. In addition, this year we're launching a pilot on patients' access to their translated health data. So what we have at the moment is that health professionals can access the data when citizens travel, but the citizens could also hopefully in the future get access to the same translated health data using a mobile app or using a patient portal. It's not so easy, it's not so difficult to join Myhealth EU. There is a preparation phase where a country needs to, of course, implement technical specifications, which are at the moment very stable already. They need to implement, they need to fix any bugs, they need to test and retest if needed. And then there is an additional compliance check, which is going also into legal, organizational parts, technical, semantic parts. It's like an audit, but we call it a compliance check. And if there are some findings, then the member state needs to apply fixes. And then when everything is ready, there is a decision phase in which the EHealth member state expert group makes a recommendation to the EHealth network. And then the EHealth network makes the final decision, and then the country goes live. You saw already that the EHealth network is one very important governance body here. The EHealth network brings together experts on digital health from all member states. And Myhealth EU is building on results of that work. So the EHealth network has developed a number of guidelines. There is a general guideline on the electronic exchange of electronic health data under Crossborder Healthcare Directive, which is currently undergoing revision, but the previous version is available. The guideline on patient summary has been updated last year, and the guideline on e-prescription is being updated as we speak. And also, there is a guideline on lab results and reports, which is in preparation. So with these documents, we need to implement them, and in order to do so, we need some tooling. So what we have as tooling is a testing platform where technical specifications are basically encoded in such a way that you can organize tests around them. And of course, we have performed quite many test sessions. So here you can see that the test sessions have been ongoing since, at least on this screen, from 2017. But before that, there are more test sessions. And now we just finalized the Wave 5 formal and upgrade pre-production test event. Specifications themselves, they are also computable, and they can be found in the art decor format. So this is more computable than those documents produced by the EHealth network. And based on these templates, countries are developing their systems. The data is coded, so we also have a terminology portal in Myhealth EU, which has the code systems used in the exchange of these data. Semantics, it's not everything, of course. So we try to fix as much as possible using semantics, but there are some business rules which also need to be taken into account. We can try to build semantics flexible, but sometimes the complexity is so significant that we end up having rules which are, let's say, a least common denominator. In the e-prescription, for example, I just put a few examples of different differences between implementations in national e-prescription systems. And the common the least common denominator is the cross-border electronic prescription. So, for example, if in some countries prescriptions are iterated, it's not directly visible here in this system. You only see one, let's say, iteration of a prescription every single time. There may be a statement saying that, yeah, there are 2 more iterations coming, but now you can only see one, and then it's possible to dispense. So then the next dispensation could be again done using the next iteration. So just an example of different business rules in different countries, which are not so easy always to implement on the semantic level. So what could be the next possible steps for Myhealth EU? I listed already some of these on the previous slide. There are some updates of the guidelines ongoing, some additional data sets to be added, and patient access to translated health data. But also, what we plan is further integration of electronic identification, support for telehealth services, and also integrations with some other infrastructures. We register quite some interest of member states on integrations with, for example, the EHIC card. But also there could be some integrations, for example, with the centralized clinical patient management system, CPMS, used in rare disease cases. And also, what we are considering is adding further mobile elements to these services. So patient access, I mentioned it already. So hopefully in many cases it will be available on mobile. And also there is the EHTEL regulation update has been proposed last year by the Commission. So there could be some integrations between Myhealth EU and the eID wallet or citizen wallet as it's made in some countries. I mentioned already that it's not always possible to have all the data structured. So maybe we can design some further extensions to original clinical documents. Maybe there could be some links between the structured and unstructured data, for example, links from certain diagnoses in patient summary leading to further details about that healthcare encounter in which the diagnosis was made. We also need to streamline further, not only because we're slow, we're actually not very slow, but it's more about the need for speed, for a need for, let's say, scalability. As more and more countries are joining, and also more and more data types are added, we need some streamlining of testing arrangements here, and hopefully we'll be able to move quicker also with patient summary and e-prescription in this case. And the last point to mention is the ethical principles. I already showed that coverage of service is not yet 100% in all member states which are live. So we need to improve that, definitely. And we should not forget some population groups, such as, for example, children and elderly, so that maybe people could purchase medication on their behalf if they're authorized to do so. Maybe they can provide consent to the use of the services using paper, which can be encoded later. So all these ethical principles should be kept, of course, in mind. The last slide for today is to say that the Commission is currently finalizing its proposal on the European health data space, which has 2 arms, if I may say so. So one is the primary use of health data, and the second one is the secondary use of health data. So in the primary use of health data, of course, Myhealth EU services is one element that is going to be quite visible. It's visible already now, but with European health data space, hopefully it would be even more visible in the future. And you can see also some elements here which are mentioned. So reinforcement of Myhealth EU, but also interoperability. So there we are working on providing some additional, let's say, tools and mechanisms to streamline the interoperability approaches across the European Union.
Thank you very much, Konstantin. You mentioned that actually you've been developing guidelines. They are updated. Those guidelines, of course, refer to a number of specifications, standards, terminologies, which are accepted, but you had also to build common resource in order for the system to be operative, right? You mentioned that you had developed templates and these results, and you let then each country to develop the system they want. So what you mean by that is that basically you have different ways of implementing that. So either a portal organized by an authority where you need to input, if I can say, all the data necessary and map them to the correct value and standards, I would say, or leaving it to the industry to do it directly. And this is it so then we have today, even for that use case, different ways of implementing it in the different countries. And what is, according to you, the evolution, knowing that, and I will link then my second remark to that, knowing that actually we built all that system for only one use case, which was cross-border care, while today we know that the number of use cases are going to explode. So we need probably a different kind of agility and flexibility and testing environment to work around that.
Yes, thank you. Indeed, there is quite a lot of flexibility for member states to implement the services, and we have seen multiple different ways of doing so. To give a couple of examples, for example, patient summary, it has been implemented through, let's say, a portal-based approach in France, which led to the 100% coverage for all points of care, which is very quick and very strong way of implementing this. However, it comes also with some drawbacks, meaning that normally the doctor or another health professional is using their, let's say, standard system. They need to switch over to something else in order to access data for cross-border patients. So it comes with this limitation. However, I'm sure that French colleagues are working on some further integrations there to resolve this problem. And indeed, this approach has many strong points as well, because you can, using this way, attain immediate 100% coverage. In the Netherlands, it has been taken through a different approach. So there, they went into full integration of this functionality into local systems, which is much more difficult to do in the beginning. But then, of course, the usability is presumably a bit better. But again, with this model, every small change that would take some time to implement in all these different systems. So I wouldn't say that there is one size fits all here, and that's why there is flexibility for member states to do it in different ways, because they have different situations. They have different designs of their digital health systems. And if we were to come and say that, guys, this is the way to do it, and that's the only one, that would have probably only made things slower.
Thank you, Konstantin. I have two more quick questions I think you can answer very quickly. So one from Leo Lewis, who's asking you is actually if the use case linked to, the data linked to social care and other support service are now being studied also.
I think there is one section in patient summary about some social impacts, social factors. So partly that data is already there. And of course, if according to the legislation of the member state, some professionals, for example, health professional working in the social sector, if they can get access to data according to the national rules, then of course they would be entitled to do so also for cross-border patients. And of course, the data which is generated in health services, if it's, let's say, in the health domain, if there are some prescriptions made in social services, if some updates to patient summary are done in social services, then of course that data is covered. So I would not say that we are dismissing social care. We already have some integrations there and some support for this use case, which is very important use case.
Okay, and the other one is actually, I think there's been some recent development around that, is we have a master set of codes, I would say, that are used to present the different data that are exchanged at the European level. And the question of the use of SNOMED CT codes has been raised. As we know, SNOMED is not you need to is protected with specific IPR, and the Commission has taken recent initiative, right? So the question is, what is then the place you would give to such a terminology in the European setup today, and linked to that also maybe FHIR, I would say, implementation.
So indeed, for SNOMED CT is used in patient summary, and it's mostly the value sets from GPS, I think, but in addition to those, there are some additional value sets too, which are used in the current Myhealth EU patient summary. And with that in mind, indeed, we provided some support, some grants to member states in order for them to get the licenses unless they have already a license. The coverage is not very bad with the license situation in the European Union, but some member states, they were not yet members of the SNOMED International, so hopefully soon there will be. FHIR, it gets a lot of attention indeed. So far, it hasn't been implemented in Myhealth EU. Everything is based on CDA at the moment, but maybe we could think about the new use cases which are upcoming. For example, lab results. We haven't yet done, let's say, CDA template for lab results to be implemented. We haven't done any implementation at the central level, so maybe we could consider FHIR for it, but I would not start, changing the specifications of the current services, and I would not go into saying that CDA is bad and FHIR is much better. So let's switch over. We need also some stability for member states to implement. So we need to prioritize the expansion of the coverage first, and maybe FHIR would be better for some new use cases.
Okay, thank you, Konstantin. I see that Vincent Kunnen has also raised his hand. I would take this last question, but please keep the discussion, the question for the panel also. So if it's a clarification question, Vincent, go ahead.
No, it's just because I was wondering if the chat is really open, because I don't see any chat on my version. But do you receive questions from other people?
Yes.
Okay, so maybe that's because I'm on the panel or something. Okay, but at least some people cannot ask questions via the chat, so you know.
No, but feel free. If you have a question, go ahead. Huh?
I was going to ask Konstantin if this will be open to industry. So is there going to be publications so that industry players can use them and for example, develop applications that could use those standards and display the data to various patients in one or several countries?
Well, the specifications, they're open. If you Google electronic cross-border health services, or you Google Myhealth EU, then I'm pretty sure you would be taken to this page. So you can find the guidelines there, and if you scroll a bit down, it's this page, electronic cross-border health services. So it lists which countries have them in production, which data contents are in production. But also you can see the guidelines published here. And if you scroll down and you go down, you will see the requirements catalog and the interoperability specifications. So to access this, you only need EU login. And then you are logged in and you can see everything, use case descriptions, semantic artifacts, everything is here.
Yeah.
Okay, thank you.
The final remark, because before I pass the floor on to Chantal, is that actually you mentioned that many of the guidelines are under revision. And actually, I think it's interesting to see that there are some major contribution coming in. Speaking about e-prescription, there is, for example, a direct link between the implementation of the IDMP standard supported by the Commission, which is bringing, obviously, here a much more global perspective and some robustness to the evolution of those guidelines. So I think from the Commission point of view, there are clearly, it's not only a process which is slowly evolving as it is, but there are major inputs coming from elsewhere to enrich the process, right?
Indeed, so I was mentioning already the EHealth project, which also received some EU funding, and there, yeah, we received quite some input from the experts in the member states. Plus, you mentioned IDMP, so for that there is a Unicorn project, and there are many other projects which are also fitting in this development.
Thank you very much, Konstantin.